who does all the insurance authorizations, make sure that we have the authorization for insurance and I'll get paid. Then they come to me. They're booked differently. They have to be booked differently because we bill different insurance. I use different codes. If I bill, except Medicare, if I bill and if you guys don't have a clue what I'm talking about with codes, I apologize. But it's actually kind of important right now. If I bill an E&M code, which you guys must do in your outpatient clinics, for a psych patient, it won't be paid. If I bill a psych code to medical, it won't be paid. So we need to know before the patient walks in the door if it's psych or medical. So I have patients who are referred to me, I see them, I establish, and I've had a number of them say, well, can't I just see you for both? And one of the things that I've given a lot of thought to is, you know, sometimes the right answer is no. And it's something we didn't address when I was in the program. What about boundaries, traditional psychiatric boundaries, when you're doing primary care too? There's also a very practical issue. If I have a very challenging psychiatric patient with a lot of neediness, probably access to, I don't want to be the only provider. I can't handle it. I need to share the pain. You know, I need somebody else who understands, somebody else to take reflections, somebody else, you know, granted they can do splitting, but you also can feel overwhelmed by the demands of somebody who's very difficult. And I tell that patient that, a number of patients I've told, I think it's in your best interest to have more than one doctor here. I think it's important that more than one doctor know what's going on with you, and that way we can cover for each other, and you will be taken care of better.
It's possible because your group is relatively small, and so you're not going to have just the less risk of the fragmentation. In other words, in training, there's so many residents that sometimes that model is not very good because the patient just went from one provider to the other. It sounds like in this setting, that's not as likely.
Oh yeah, we have wonderful coordination there. In fact, I have stopped taking Medicare patients from, actually I've stopped taking anyone from outside our group. Anyone who doesn't have a PCP in our group, I won't see anymore. It's so much harder for me to coordinate care. Within the group, we have a single EMR. We have a confidential category for psychiatric notes, but providers have access to that. We talk to each other. You know, we meet each other's in the hall, and I love that model. One of the things I really see, the Kaiser people aren't here to defend themselves. One of the things I really don't understand about Kaiser is they have psychiatry, they pay for psychiatry, they have mental health, but they've kept the silly silos. And one of the things that's so nice about practicing in an integrated model, and there's a whole lot of thought about integration of care, and I'm not the only one, and we're not the only ones who are thinking about that right now, is you really can improve the quality of care. And while I recognize there are certain aspects of psychiatry that are very private and personal, the fact is, somebody who's in a lot of distress over very private and personal things will go to their doctor because they don't have access to a psychiatrist. And much of the psychiatric issues we treat today, we treat medically. And so from a practical standpoint, most patients aren't lying on a couch fantasizing about stuff that would look really bad if it got hurt. And most of it is pretty, you know, your wife is sick, she's got cancer, chemotherapy, you know, I'm upset. Yes, it's very personal, but it's not outside the realm of what can be shared and what reasonably should be shared among providers who are trying to take care of something.
Karen, can I ask a question? So, within your primary care medicine clinic, do you think you're better equipped to deal with the psychiatric issues that pop up? In fact, do you treat both psychiatric and medical stuff in your clinics?
Personally?
Do you, yeah.
Yeah.
So it sounds like you do.
So last week, I had a guy come in, follow up for depressions. He's one of our internists, also seen by a neurologist because he has MS. And he'd been kind of in denial, minimizing his depression symptoms. But he came in, he was hypotensive, he was hypoglycemic, and he was in acute, his second episode within a week of acute on chronic renal insufficiency. So instead of having a psychiatric visit, once we realized he was hypotensive and kind of gray appearing, and he couldn't actually walk all the way back to the office, we check a few other things. We give him water, we recheck his blood pressure, I sent him to the lab, and he ended up going to the emergency room. I had a lady who came to me early on in my career who had a syncopal episode at work. And I could order the EKG, I could order the Holter monitor, and get all that done. It is so much easier to get any kind of medical workup done on any of these patients. You know, I just can't say enough about an integrated model of care.
Yeah, I was just curious because you're outside of the university setting. If you could talk a little bit about when you were looking like outside of the university setting at different practices, how you were received as someone who was combined trained, and if your experience was you kind of had to, you know, convince people of like what position you should have, or if they kind of looked at you funny, or if people were receptive.
Well, the reason, very frankly, the reason I ended up at Woodland Healthcare is I made an effort in my, I think it was in my third year, the end of my third year, to do a 2-week elective there on the med psych unit because I wanted to find out what their med psych unit was like. What I discovered is it's just like Schmick, except if you've got an electrolyte imbalance, you can get an IV. You know, I mean, or you can, and you can have oxygen. I mean, that's really kind of it. Because if somebody, for example, this one woman had to have a gynecologic surgery while she was admitted there, maybe they transfer her to med surg. You know, they're not going to keep someone who's immediately post-op on the psych unit. But when I was there, I talked with the medical director at the time, and I told him the question. He said, very interesting. So when you get closer to being done, come back and talk to me. So there was already an understanding, already a perception of this. By contrast, I was very interested in Kaiser. One group in Kaiser, medicine, general medicine, was very gung-ho, and the psychiatry side was like, you know, we really need to do this and this and this and this, and, you know, no imagination. You need to find a place with imagination, with an ability to kind of stretch the limits of things because it makes sense, as opposed to having the way things should be. There was another group in Kaiser that I talked to. The chief of medicine was gung-ho. Thought it was the coolest thing since sliced bread because he'd actually been a psych tech before he went back into family medicine. The chief of surgery, or I'm sorry, chief of psychiatry thought it was a great idea. Yes, let's do this. The requirement there is I have to be 60% medicine, 40% psychiatry. But they rounded up the flagpole. Both of their bosses said, "Oh, I don't think that'll work."
Did they give you a reason why?
The chief who talked to me said, well, no, he didn't give me a reason why. And he said, well, if it doesn't work out where you're going, why don't you get back to me? I think it was because it wasn't the Kaiser way. A smaller organization can move more nimbly, can do things quickly, and do things a little outside the box. So I think the culture of the organization is really important. It would be really neat if you guys could figure out how to identify where in the country people are thinking creatively and doing integrated care models in order to kind of have a